Hi, welcome to Dr. Vic's Academy. Today we will be talking about depression. DSM-5 Diagnostic Criteria. A easy way to remember the DSM criteria is to use the ASAD faces mnemonic for the core symptoms of depression, of which at least 5 symptoms must be present during the same 2-week period. And at least one of the symptoms must be dysphoria or depressed mood, or anhedonia or diminished interest. The symptoms must be significant enough to cause functional impairment. The episode is not due to effects of a substance or medical condition. The episode is not better explained by schizophrenia spectrum disorder or other psychotic disorder. There has never been a manic or hypomanic episode. Screening. Risk factors for depression would include those with a personal history of depression, family history of depression, and/or chronic medical problems. The Canadian Network for Mood and Anxiety Treatments, or CANMET, has recommended a 2-question screen as follows. In the last month, have you been bothered by little interest or pleasure in doing things? In the last month, have you been feeling down, depressed or hopeless? An answer of yes to either question should be followed by a more detailed assessment. Assessment. The basic assessment for depression begins with the detailed history of the presenting symptoms, the severity, level of functional impairment, including life events and stressors, and duration of the current episode. A brief screen for prior depressive episodes, manic or hypomanic episodes, substance use and pre-existing medical conditions should be included. The patient's personal history, including social background, past psychiatric illness, and family history of mental illness, depression and suicide should be established. In this regard, time should be spent on establishing therapeutic alliance with the patient, determining life stresses as well as sources or support and personal resources. Collateral information should be gathered where possible. A mental state examination should be included as part of the assessment. This includes an evaluation of the severity of symptoms and a screen for psychotic symptoms. It is also necessary to establish the risk of suicide, self-harm, and risk of harm to others. A physical examination, and indicated laboratory testing, is indicated to rule out a medical or surgical condition that may cause similar symptoms. Assessing suicide risk. One of the tools used to assess suicide risk is the SAD Persons Scale. This is a 10-item mnemonic with a maximum score of 10 points. Close monitoring of patients is needed for scores of 3 to 4. Strongly consider hospitalization for those with scores of 5 and 6, and hospitalization for further assessment for patients with scores of 7 to 10. Pharmacological treatment. Principles of treatment. In the acute phase of treatment, which lasts from 8 to 12 weeks, the primary goal is to eliminate all signs and symptoms of depression, and restore the patient to their pre-morbid level of functioning. It is important to aim for full symptom remission, because residual depressive symptoms increase the risk of relapse and worsens the long-term prognosis. Medications should be titrated until appropriate therapeutic doses, or if further referral is needed. Choice of antidepressants. The selective serotonin reuptake inhibitors, or SSRIs, and newer antidepressants remain the first-line drug of choice for pharmacotherapy in depression due to better tolerance, safety in overdose, and favorable risk-benefit ratio. Newer antidepressants include serotonin and norepinephrine reuptake inhibitors, or SNRIs, and noradrenergic and specific serotonergic antidepressants, or NASSA. Ultimately, the choice of antidepressant should be tailored to the patient's profile, symptoms, and personal preference. Consideration should be made into the patient's comorbid medical conditions, potential drug-drug interactions, pertinent side effects and patient's tolerability towards these effects, cost of medication, and previous use of antidepressant, if any. Older antidepressants such as tricyclic antidepressants, or TCAs, and monoaminoxidase inhibitors, or MAOIs, should not be used as first-line pharmacological treatment due to potential side effects and dangers in overdose. Review and follow-up. Patients should be reviewed frequently following commencement of antidepressants, to monitor compliance, side effects and improvement in symptoms. Dosage of medication should be titrated according to symptoms and tolerability. The frequency of monitoring would depend on the severity of the depressive episode, suicide risk, patient's willingness to come for follow-up, and availability of social support. Suicide risk assessment during follow-up. Even with treatment, suicidal thoughts, plans and attempts are prevalent among patients with depression. Therefore, every clinical encounter should include an assessment of suicide risk. This is especially important in view of black box warnings issued by many regulatory agencies, on the increased suicidality associated with antidepressants, particularly in adolescents and young adults. Maintenance and prevention of recurrence. Once the patient has been stabilized on a particular dose of antidepressant, and depressive symptoms begin to respond and remit, maintenance treatment should be considered. In this phase, the primary goal would be to prevent recurrence. This phase would require monitoring and continuation of medications from 6 to 24 months, or longer, depending on the patient's risk factors for recurrence. Such risk factors would include past episodes of depression, indicating a risk of recurrence, an earlier age of onset, poor social support, and ongoing psychosocial stressors. Discontinuation of medication. Patients should be advised on the risk of symptom recurrence, or a full relapse, if medications were inappropriately down-titrated or discontinued. There is also a risk of discontinuation reaction, if treatment were abruptly stopped. However, if the patient is stable and well after an appropriate period of maintenance, discontinuation can be discussed, taking into account the patient's current psychosocial situation and readiness to stop medication. A gradual tapering of antidepressant is recommended, at a minimum of 4 weeks or longer, to reduce the side effects of discontinuation. The patient should also be advised that the highest risk of relapse would be during the initial 6 months after medication is completely stopped. Non-pharmacological approaches. Psychological treatment. Psychological treatment remains a viable option, allowing the patient to establish treatment alliance with a trained therapist, alleviate psychological symptoms of depression, and prevent or correct maladaptive patterns of behavior. It is an established form of treatment, and can be used as first-line treatment alone, in cases of mild to moderate depression. Psychotherapy should not be used in patients with severe symptoms, such as psychomotor retardation. Instead, such patients would benefit from pharmacological treatment. The decision for psychotherapy should be determined by the patient's choice, his suitability to undergo psychotherapy, and the availability of a therapist. Psychotherapy may be of particular benefit in patients with significant psychosocial stressors, interpersonal difficulties, intrapsychic conflict, or have a comorbid personality disorder. The form and duration of psychotherapy may be determined by the therapist whom the patient seeks for psychological treatment. However, the patient should continue to be reviewed by the treating physician on a regular basis to evaluate improvement of symptoms. If there is no or partial response after 4 to 8 weeks of psychotherapy, antidepressants should be considered. Psychoeducation and family intervention. During the course of treatment, it is important to continually educate the patient on the illness, the need for adherence to treatment, and to instill in the patient a hope for recovery. Lifestyle advice such as exercising, stress reduction, and strategies on reducing anxiety, should also be part of the psychoeducation process. Family members or trusted friends in the patient's circle of social support, can be involved in the patient's treatment and recovery. This is particularly important where there is a risk of suicide. Where indicated, patients can be referred to the community or family service centers for individual counseling to develop coping strategies to help with immediate issues and stressors. Couples or marital therapy may be warranted, especially if marital distress is contributing to the patient's depressive symptoms. A referral to a community-based social worker may also be indicated to assist the patient or family in managing ongoing psychosocial issues, such as financial difficulties. Physical treatment. Several forms of physical treatments for depression exist, including electroconvulsive therapy, repetitive transcranial magnetic stimulation, and transcranial direct current stimulation. However, these are not considered first-line modes of treatment for depression, and further referral to specialist or a facility with the appropriate expertise and equipment is recommended. Further referral. A referral to a psychiatrist and/or an appropriate medical/psychiatric facility should be considered under these circumstances. Diagnostic difficulty. Treatment resistance whereby patient does not respond to 1 to 2 trials of medication, or needs combination therapy. Complex psychosocial and medico-legal issues. If the depressive episode is associated with high suicide risk. If symptoms are suggestive of psychosis or mania emerge. Severe perinatal cases, especially if there is risk of harm to the child. Comorbid medical conditions with potential drug-drug interactions. Comorbid substance abuse. Any other situation where more urgent or intensive treatment is required, such as an admission or electroconvulsive therapy. Conclusion. Depression is a highly treatable condition that is responsive to antidepressants and psychotherapy. It is important to address psychosocial stressors that have contributed to, and which may perpetuate, a patient's depressive symptoms. The patient should be regularly reviewed to ensure there is response to treatment, and further appropriate referrals to a specialist can be made if indicated.
Audio Jungle. Audio Jungle.